Okay, all right. Well, here I am with Dr. Ho, who is a medical doctor just right up the street from our clinic here at Rhodes Chiropractic. And he's a medical doctor and he has his PhD. I tell our patients I have a PhD too. It's called a perfect hair day. That's my only PhD. But I want to introduce you. We've referred a lot to you. We love using you, Dr. Ho. You're great with patients and add a lot of value. But I want to introduce you. You're obviously the owner and doctor of Nerve and Pain Institute right here in Tigard, Oregon. And you're also a neurologist. So you're a neurologist and you do pain intervention. And you got your PhD and MD at University of Iowa, correct?
That's correct.
And then you've done training beyond that at Stanford and University of Florida.
Mm-hmm.
Can you remind me what did you do at University of Florida and then at Stanford?
Yeah, so I did my residency in neurology at University of Florida and then my pain fellowship, which was at Stanford.
Wow. So in total, how many years were you in, let's say, college to graduate?
So post-college, so it's 8 years MD PhDs, 4 years residency, and 1 year of fellowship. So that's total of 8 plus 5, 13.
13 years.
Undergrad, and that's, 17 years total.
Wow.
Yeah.
Well, that's quite the accomplishment. And you have over 30 peer-reviewed studies in various medical journals, right?
Mm-hmm. That's correct.
That's right. And you're also a husband, a father. You got a 2 and a 3-year-old at home.
Yeah.
Busy guy.
Yeah.
And you made time to come here for our podcast. So I want to thank you for taking your time out of your day to be here.
Yeah.
It's amazing that you've had all these accomplishments, and I find that you're very humble and very approachable. So I appreciate that in you. And so, real quick, I'm excited to have you on here because we do refer quite a bit to you, and I'm excited to ask you questions regarding what you do with some of the pain intervention and the injections and the therapies that you provide. And so I'm excited about that. But real quick, before we get into that, anything you wanted to mention about yourself personally, your family, your education? I just want to make sure I didn't leave anything out.
I think you talked about pretty much everything, except that I do rock climbing on a daily basis. Other than that,
on a daily basis?
Close.
Weekly.
Yeah. Well, actually, daily. I do usually go rock climbing right after work.
That's awesome.
And then I go home.
The circuit?
There's tickets.
Okay.
Tickets, yeah.
All right. That's awesome. So you might see him there, but he's not on the clock there. So
that's right.
Well, I'm excited to ask these questions again. These are common questions that us chiros get and that we're curious about. And sometimes, us chiros or even PTs or, NDs, general practitioners, we're not quite educated on all these procedures, but they're common that a lot of people ask us about and do. So I'm excited to educate our audience and myself about a lot of this. So if you could just let us know, what is the ideal patient for your practice? When should someone like myself or a patient consider seeing yourself for pain intervention? Is it when chiro fails or something that's seen on MRI? Could you discuss that?
Mm-hmm. Yeah, so there's really no requirements that you have to finish some therapy first before coming to see me. So really anytime you feel like, hey, things I've been doing that's not working, you can usually come see me. What I usually tell other referring providers is that if you have pain that's over 3 months, if you tried some medications and then maybe chiropractic care, maybe physical therapy, maybe something else, you've been trying for 3 months and nothing truly works and pain is still there and it's affecting your daily, whether it's sleep or work life, feel free to come see me. And then if I say, hey, no, everything looks good and continue chiro, that's perfectly fine. And I may say, okay, this is what's going on. There's something we can potentially do to make you feel better, then you don't have to continue to suffer. Because some people wait for a long, long time, maybe many years before they come to see me, and I'll be like, well, you should have come earlier. But have
Right. Right.
at least I help people to derive to the right whether it's the right therapy or right, it may be surgeon. So sometimes it's really need a surgical intervention. So I'll be able to direct you to the right person.
Okay.
Yeah.
So with that being said, does someone or do you need an MRI in order to properly evaluate that person? Or if, like you said, someone's in pain, let's say they're seeing a chiro, there's no MRI, maybe there's an X-ray, can go straight to you? Or do you require that they need an MRI for you to really see them?
No, it's not a requirement.
Okay.
In fact, you don't even need referral to see me. You can directly call my office and then come see me. And then if I think MRI is needed, which I often do get them, and I will get MRI for you.
Okay. So I think a lot of people don't know that they just call you after they listen to this. Hey, I think I need to see this guy, and just call your clinic and directly get an appointment. Okay.
Correct. Yeah.
That's cool. Now, what is the, let's say, top 2 procedures that you do at your office? I know you do a host of different things, and we'll get into that, but what would you say are the top 2 procedures that you're doing on a daily basis?
Yeah, so probably the most common are medial branch block and radiofrequency ablation. That's more for just pretty common neck and low back pain, and then epidural steroid injection, which is more common for nerve impingements like sciatica type of pain. So like arm pain, radiating leg pain. These are probably the most common procedures.
Okay, so those are kind of the top 3.
Yeah.
Okay, I might tweak those out a little bit.
Yeah.
So with what a lot of people hear about is epidural steroid injection. I hear that a lot, especially chiros, a lot of sciatica, things like that. So if we do have an MRI, we can see the problem, confirmed on there. We send them to you. You agree, yeah, this is something that I would think they would benefit from. What does that look like for a patient to come in, have you evaluate them and get the procedure? Could you walk someone through what that looks like? Are they under anesthesia? Are you using image guided, and technology? Can they work the next day? Can you kind of walk through that?
Yeah, definitely. So usually while you come to my office, usually I do an initial consultation. So I will go over your history, look at your imaging if you have any, and then do exam, and then decide what's actually going on, and then we'll come up with a plan together. So let's just say theoretical patient who has sciatica or pain that radiates down the leg. There's an MRI that shows a disc herniation that's pinching on one of the nerve roots, say L5 nerve roots. And it is classical pain going down radiating down the leg. And I'll say, okay, this looks like a radiculopathy. I think an epidural steroid injection will be a good therapy for you. So then what I will do is we'll get authorization from the insurance. And then most of the time it's covered by insurance.
Okay.
A lot of times it's really just a copay to come see, even doing these procedures. Obviously it depends on exact insurance you have.
Sure.
And then, so for the procedure itself, most of the time I do it in the office, so without anesthesia.
Okay.
But you do have the option to say, hey, if you're anxious about it, I can give you like oral Valium to sort of calm you down. If you say, hey, I want to be under anesthesia, I want to be in twilight, I have the option to doing the surgery center. So I'll be a person who will be monitoring you, will be either anesthesiologist or nurse anesthetist will be monitoring you, and then what we can do under anesthesia. As for the procedure itself, it's pretty quick in general. So epidural injection typically takes 10 minutes to do. So you walk in, I give you some local anesthetic on the skin. It's like, so for example, epidural steroid injection is kind of like the epidural you get when you're giving birth. So everyone does it when they're awake, and then you do it. It's very quick, and you're on the table for 5 to 10 minutes, and then most of the time it's not really painful. Some people don't even really feel it.
Okay.
When we're doing injection, and then when you're done, you just most of the time you walk out.
They can walk out. They're not on a wheelchair. They're not in a wheelchair. They can walk on their own accord.
Yeah.
Okay.
Just walk out of the procedure room. If they're driving, some people even drive themselves. I usually recommend having a driver just in case. But if you don't have a driver, we should have you sit for a little bit before you go, making sure you're still walking fine. And then some people go back home or work after this, and then just really no restrictions afterwards.
Okay.
And so you can do your yard work, do your regular duty for the day. If you want to rest for a while, that's totally okay as well.
You just said right there, maybe it's not always clear what exactly the right procedure is for them. If someone has multiple issues, multiple segments, it's kind of hard to isolate where their pain's at. Would you say that is common, where you target one area that maybe that didn't bring quite the relief or no relief, and then all right, let's shift gears, let's try this? That's a fairly common thing that you do.
Yeah. There's some guesswork. There's so many things that can go wrong in the low back. There's a little bit of guesswork involved, and then what I usually do first is usually my best guess.
Yeah.
And I don't always guess correctly. I'd say 80-90% of the time I'm correct.
Right.
The first time, but sometimes still doesn't always work. So there's some guesswork we have to. So if this doesn't work, we have to try something else, target a different cause of the pain, and see if that works. So if the first time doesn't work, it doesn't mean we didn't hit the right area, just that we didn't pick the right spots to target, so the right cause of the pain.
Right.
Yeah.
So many times, or sometimes, it might be boom. They feel. Is it common for someone to get one procedure and feel significant, let's say 75% relief, and then that's definitely it?
That's correct.
And then is there often additional follow-ups, like, okay, they're 50% better now, all right, let's do another one, let's hit that area? Can someone do 2 or 3 right in a row?
Yeah, that's correct, depending on exactly what kind of procedure I do. So for example, medial branch block that we talked about, which is used for what we call axial low back pain or neck pain, almost right away, like when they walk out of the room, walk out of the clinic, they usually feel 80% better already. Yeah, it's really quick.
Okay.
And some people come in with a cane and then walk out without the cane. It's like,
wow,
doctor, I don't feel any pain.
Yeah.
I can walk straight now. But the medial branch block is meant to be a diagnostic injection. So
that's not necessarily a therapeutic. Better.
Yeah, so it's therapeutic and diagnostic at the same time.
Okay.
It's just that it's therapeutic short term. So I always tell my patients that it lasts for at least for a few hours to a few days.
Okay.
And then the pain may return. Sometimes, usually in younger patients, sometimes it can last for a long, long time.
Okay.
I had a patient for whom it lasts for 2 years.
Wow. Okay. That's great.
And then came back afterwards and said, hey, it lasted for 2 years for me. I was like, wow. Great.
It's only everybody.
Yeah, exactly. But then let's say it only lasts for a couple hours to a few days, then usually repeat one more time to confirm the location. Say, hey, it really is location. This is the location that hurts. And also they really to make insurance happy about it. They don't have 2 sets. In order to authorize the procedure called radiofrequency ablation, which will usually last for about half a year to a year, sometimes 2 years. That's the really long-term therapy for that type of procedure and pain.
So in layman's terms, is that burning the nerve, killing the nerve? Is that what it is?
Yeah. So in layman's terms, it's exactly what it is. So it sounds scary, but but it's actually not that scary. So it's very similar to a medial branch block, which is just using needle placing at the right area, and then the only difference between just a regular injection and a radiofrequency ablation is that the needle tip is exposed, and then use a very high frequency electricity. It's about 50 kilohertz, and it heats up to about 80 degrees. Locally, very, very tiny. It's actually a very, very circumscribed area. And then it creates a very small burn of the adjacent tiny nerves, and actually don't feel much of it when we're doing it. may feel some warm sensation, and that's about it.
Wow.
Yeah, and takes about a minute and a half.
Okay. So it does sound a lot scarier than what it is.
It is.
Okay. Okay. When you hear nerve ablation, that sounds like it's going to smell, like it's going to hurt.
But no,
The outcomes, yeah. If you isolated it with the medial branch block, you would say the success rate is pretty high on the follow-up ablation. And that can bring half a year to a year. And I can speak, I've had some patients that have done that with you, and they still, years later, are feeling a lot better.
Yeah.
So you would say those are the most common procedures, the epidural steroid injections, medial branch blocks, and then the nerve ablation.
Yeah, those are the most common.
That's the most common.
Yeah, simply because most people have neck pain, back pain, and radicular pain. Those are the most common ailments that we get as we age. So
now, let's say a chiro is sending you a patient and they have an MRI, do you ever need to order an MRI with contrast? I've sent to a few pain interventionists, and they said, hey, I need to order this to see more stuff. Is that something you commonly have to do, or?
Rarely. Yeah, rarely. So the only time you want to order MRI with contrast is, one, if you're worried about, let's say, infection. Two is tumor.
Right.
Those are probably the only two things that you're worried about. And three, let's say if there's demyelinating disease like multiple sclerosis, some sort of inflammatory, active inflammatory disease you want to look at.
So most of the time you can use the MRI if it was within the last 6 months?
Yeah, usually they say 2 to 3 years. As long as your symptoms is the same, there's not a huge change in your symptoms, then 2 to 3 years is usually okay with me.
Okay. Yeah, that's great to know. And how many times can someone see you, and how many times do you usually recommend, or is that just, it totally depends on the patient? Is it they can only, let's say they're getting relief 25, 50% better, 75. How many times can they see you in a year?
There's no limit.
Okay.
You know, insurance definitely doesn't give you a limit on it.
Okay.
There's a limit on how many certain procedures you can do per body part based on each insurance requirements and adaptation. But like to see me, I mean, there's no limits as to how many times you can see me or do certain procedures.
Okay. But let's say like a cortisone injection into the knee. Is that typically you should only do that 3-4 times max a year? Is that true?
So it's a question mark. I would say it's less, but question mark. So that's so now we're talking a cortisone injection into the knee and shoulder joints. So it's our joints steroid injections. So we know that steroids, if you do it too many of them, you can cause some degeneration of the joint space. So that's what we know. How much is too much? Nobody knows. That's the problem, is we don't know how much is too much. So in general, I tell my patients, if you're doing more than, let's say, once a month, that's probably too much. I mean, I think 4 times a year, it's probably within the norm. It's okay.
Okay.
But I know some people would suggest no more than 3 your lifetime. I think more in the just on the kind of radical side of things. Or sure, some doctors would even say, I'm not going to inject any steroid at all.
Okay.
And so I'm more on the side of, okay, if it makes you feel better, if the other alternative is to do a knee replacement,
right,
why not just do this?
Start here.
And we can, if it makes you feel better for a couple months, we do it repetitively. You know, if you really want to do a knee replacement, go for it at a time point. But if we can prolong that, right, for as long as we can, that'd be perfect.
So some people might say to me, or with a steroid injection or injection of some sort, that, oh, I don't want to do that, it's a short-term pain relief. Would you say, well, sometimes yes, but sometimes it brings long-term permanent relief? Yeah, I mean, that's kind of a common misconception that, oh, it's a short-term relief. always,
Hmm.
and that's just not true, correct?
That's not exactly true, and obviously it also depends on the exact cause of the pain, where is the location of the pain, what procedure we're doing, how old you are, what pathology we're looking at. It really depends. If you're young and healthy, 20, 30-year-old, sometimes one injection, that's all you need. And then you're better for sometimes forever.
Okay.
Obviously, if you're 50, 60, 70-year-old, and then you have lots of arthritis, and then to say one injection to go away, it's a little bit harder. Probability wise is going to be lower compared to if you're younger, 20, 30-year-old.
Would you say that, let's say a chiro or PT, someone, or like our clinic, that your work that you are doing, if you're helping them out with one of these procedures, they can continue this care, and it probably is even going to help them and advance them in their healing journey with all these other, conservative care measures, with adding you in so they can do both.
Mm-hmm. Yeah.
And that would actually accelerate their improvement.
Yeah, it's actually better. Multidisciplinary pain treatment has been shown to be superior to just doing one thing, let's say just doing injections alone. So definitely, I think doing both is totally okay and better. And especially in a case where you have lots of pain and you cannot tolerate, like say, either chiro or physical therapy,
Right.
I can make their pain feel better, and then they can do chiro physical therapy, and then they can probably accelerate the healing process.
So it doesn't have to be, because this comes up, patients almost think, or even providers think, it's one or the other, and it really can be a team effort.
Yeah, exactly.
Okay. And obviously you're chiro friendly, PT friendly. I mean, we're on a texting basis. Hey, this is what's going on. And so you're a great communicator and work with your, referring providers to come up with a game plan, and often say, hey, yeah, come back in a couple months, keep doing your PT, keep doing your chiro. That's a pretty common practice.
Yeah, that's pretty common.
Okay, awesome. And then how do you know, just for patients kind of visualizing, okay, I think I need this, or I'm going to inquire about it. They're laying on the table and you're going to inject them. Are you using some sort of image guided technology to know exactly where you're injecting, or is it just a blanket, we're going to inject in this area? Or is it both, if it's like a trigger point injection or?
Yeah, most of the procedures I do are guided by usually X-ray, colposcopy, especially if it's in the spine, so neck, low back pain. I also use it for just straight shoulder and knee joint injections, even though we can use ultrasound or blind procedures for those.
Okay.
There are certain procedures I do it blind, like Botox injection, migraines, greater accessible nerve block for kind of headache. So trigger point injections, which is just injecting numbing medicine into muscles. Those I do it blind.
Okay.
Yeah.
So, I mean, we just hit on something we haven't really talked about, but you do Botox for migraine headaches, trigeminal neuralgia, jaw issues too, or mostly the headaches?
So Botox, I do it for migraine most of the time.
Okay.
Botox, some people do it for TMJ pain. And there's some talks about using Botox for trigeminal neuralgia. Neither are paid by insurances, and so I don't offer it on a regular basis. But I know there's some. It can be ENTs, can be plastic, can be aesthetic clinic, can be even dentists. Sometimes they do like TMJ related Botox injection.
Okay.
Yeah.
Well, that's good to know. I think a lot of people don't realize that even Botox can be used therapeutically. Just in our society, you think more of aesthetically.
Yeah.
But therapeutically, it can be used.
Yeah. Exactly.
What about a translaminar injection? Is that just more of the location that you're injecting in then, right? It's more of the anatomy, or?
Yeah, so there are different ways to inject. So you're talking about epidural steroid injection, which is used for sciatica radicular pain, where there's pinched nerve to relieve inflammation of the nerves. So there are ways that you can inject that nerve. So there's what's called interlaminar approach, and then there's the transforaminal approach. So interlaminar approach is kind of like the way you get epidural when you're pregnant and giving birth. And you can actually do it blind. That's how you do it when you're giving birth. You have to do it blind without X-ray approach. Transforaminal approach, which is these the holes and tunnels called foramen's, and so this is where the nerve root comes out. So that when the nerve is irritated, that's when you feel that string and sciatica, the pain that's shooting down your leg. And so within that hole, there's the nerve, and then there's epidural space. So you can use a needle to sort of walk into that space and inject medication. So those are the two ways to treat the pain.
And it depends on where you're seeing the problem, what approach you're going to take on that.
Right.
Okay.
The interesting thing is, so there are these two approaches, but nobody truly knows which one is better. Actually, quite a few studies on it, and then I think most of the studies are it says one is better than the other, or for certain conditions. Some studies says they are exactly the same. There's no differences. My preferred approach nowadays is using interlaminar approach because it's less painful, and then it can hit multiple nerve roots at the same time. It's less diagnostic than the transforaminal approach. So that's if you're, for example, you're a surgeon, you're a neurosurgeon, and say, I want to see if it's this particular nerve root that's irritated, and whether I can operate on this particular nerve roots. Then you will want to do something, the transforaminal approach, because you have to target that very specific nerve root by blocking that nerve roots.
Got it.
Yeah.
Okay. Yeah, thanks for sharing that. A couple other different things that you do. I think we hit some of the main ones, but you also can work on the SI joint. You know, there's a lot of patients in here with back pain, but it's really sacroiliac joint pain. You often inject in that area, and that can provide a lot of relief too. And
yes,
so it's not just the main spine, but also the SI joint as well.
Yeah, definitely. Yeah, so sometimes it's mistaken as low back pain. So SI joint is right below the low back, and then it's a little bit lower, a little bit more on the side.
Does that one hurt?
You mean the SI pain or injection?
The injection.
Injection. It's similar to the medial branch block that we do. It's one shot. If it's only one location on the left side, it's one shot. If you have two, both sides, it's both two shots.
Okay. I believe you do this as well, but correct me if I'm wrong, is you actually, if someone's in a lot of pain, and maybe some of these procedures didn't work, but that there's nerve stimulators that you can implant in someone's spine. Can you talk a little bit about that and when that would be used?
Yeah, definitely. So spinal cord stimulation has been there for decades. It's been there the first ones implanted was in 1970s. So it's been there for 50 to 60 years. And then it's really exploded in the past, I would say 15 years. And there's competition in this field and very, very good evidence that it works very well, like multiple randomized control studies showing that it's really effective for many medical conditions and painful conditions. And then so now there's competition in this field with multiple companies, and they're all trying to innovate. And so there's a lot of innovation in this field, and they're all getting better and better every year. And they're truly very effective
at relieving back pain.
Like back pain.
When maybe they can't have surgery or they don't want surgery, and they've tried all these other conservative measures. Is that kind of the right candidate for that?
Yeah. So predominantly, I think the number one patients, actually the most common condition that we treat with spinal cord stimulator is what we call failed back surgery or post-laminectomy syndrome.
So after they've had a surgery, they're still having a lot of pain.
Yeah. So if you have some sort of back surgery, you still have persistent pain, then spinal cord stimulator is a pretty good option. Actually, there is a study comparing people who had back surgery and still have persistent pain, whether spinal cord stimulator is superior to repeat surgery. And then so this is a group of people who still have a lot of pain with back surgery. And then half the people, they get spinal cord stimulator. The other half of people say, okay, we're going to repeat surgery. And then most of the people who got the spinal cord stimulator is like, oh, feel great. And then and most people who had second surgery still has a lot of pain. And most of them, they eventually cross over to the spinal cord stimulator arm because they get pain, they get much better.
So this is a device that is implanted in their back.
Well, it's not truly there's a little wire that's sort of in the back, and the battery is kind of like a pacemaker. That's underneath the skin.
Yeah, but it's not like a device they have to have on their side.
So it's placed roughly by the love handle area. So unless you push on it, you shouldn't feel much of it. Yeah.
Yeah,
and then usually you plant it pretty high up, and as I said, in the love handle area where there's plenty of fat. So usually doesn't cause too much of irritation.
Yeah, that's great. I mean, we've definitely have had a lot of patients come in. They've had, multiple surgeries, and there's some where I'm like, I just don't know if I can help you, and that could likely be an option. So I could do a consult with you and see if that would be a good fit.
Yeah, and the good thing about it is that you don't have to implant it right away. So if you're questioning, is it really gonna work? Is it really for me? Will I like it? There's something called a trial. We always do a trial process. A trial process is not a surgery. So it's just like epidural steroid injection I do in my office. And then instead of injecting medications, I'm injecting those small wire. And take out a needle. You wear this kind of little small wire on your body with the battery sort of taped on your skin. And you wear for a week. By the end of the week, if you say it didn't work for you, then say it's okay, we take it out as if nothing happens. And then it's not a surgery, you can always say, I don't want to do it. And if you say, hey, it's life-changing, my back pain is so much better, and we're looking at greater than 50% pain relief. If you don't get 50%, if it's like 20, 30%, I was like, 10, 20%, we don't want to implant something that doesn't give you good relief. So, and once you feel like, okay, something I want, it's really helpful, and then we can implant it for you afterwards. Yeah.
If someone's listening to this and kind of thinking through these different procedures, but thinking, but what about the side effects? What would you say, the percentage of infection or, negative side effects? Would you say it's quite minimal?
So the trial,
not just of this, but all the procedures that you do.
Minimal, close to none.
Really?
So, for example, medial branch block for neck pain, low back pain, it's just numbing medicine. So it's no steroids. It's reversible, and so
there's no potential for something majorly negative to happen with most of these procedures, or at least it's minimal.
It's minimal. I mean, like you take Tylenol. Tylenol says you can try.
Right.
You can't say, I cannot 100% say, okay, it's not without risk, but it's minimal risk.
I think that's good to know. Because some people I think are out there and maybe, these common, chiro, PT, or their procedures just aren't working for them. And maybe they're scared that something really bad's going to happen if they, have one of these procedures. But speaking from someone that does this day in, day out, it's quite minimal as far as negative side effects.
Most of the time it's fairly safe. And it's even safer when you're actually awake and doing these procedures. I know people don't want to have any pain when having some of these procedures, but it's actually safer when you're awake. So if something went wrong, and then you can give the feedback to the doctor and say, hey, it really hurts, what's going on? And then be like, okay, maybe there's something going on, and you can troubleshoot. And that's actually safer than if you're totally asleep. And you're just doing all your own thing. So
got it. Let's see. What are some of the other questions here? That's a common thing. We get sometimes some pushback if we really think someone's going to benefit from you. Like, I'm just too scared. I'm just too nervous about it. But I think that's one big part of having you on here is to kind of clear the air about it. And you also do, we were talking before we went live here, but you do nerve conduction studies. Can you tell our audience what is a nerve conduction study? And I know there's a lot of chiros and other practitioners that want to get these studies and they're just not sure who they can refer to do it.
Mm-hmm. Yeah, I do those. So nerve conduction study goes along with EMG or electromyography. So it's a study to look for nerve damage, so that can be looked. Most commonly, it's used for usually like carpal tunnel syndrome. That's probably the most commonly fixable nerve problem that can be done and use EMG for.
Okay.
And then so people who have like weird numbness, tingling, weakness, they may want to have this study to see, okay, what nerves are damaged. Is it in your hand? Is it in your arm? Is it in your neck? Is it somewhere else? So it looks for those conditions. Yeah, so I do those.
Okay.
And then it's usually not very painful. It's not without pain, and but something I can do on myself all day long.
Okay.
So I give you some low electric shock. That's that's the nerve conduction study. And then there's some small needle I have to put into different parts of the muscle groups to look for nerve damages there. That's the EMG portion of it.
That can be done on the arm, but sometimes in the leg too.
Yeah.
To figure out if the nerve is healthy, if it's dying, basically.
Okay, that's right. Look for acute nerve damage, chronic nerve damage, sometimes muscle problems, genetic muscle problems, neuromuscular diseases. Yeah.
Okay.
Those things.
That's great. Yeah, I didn't know that you did that. That's great. And kind of last thing here, you are a neurologist as well, which isn't that common. And I don't think a lot of people that maybe even know you and refer to you know that you are. And so someone, if they need a neurologist, they could call you, they could come in, and maybe it's not, back pain, sciatica, but it could be, maybe they're having unexplained dizziness and headaches, or, maybe someone said they had MS. Or so can you talk a little bit about you being a neurologist? What kind of conditions can you help diagnose and help people out with?
Yeah. So I'm a neurologist by training, and with a fellowship training in interventional pain.
And that's pretty rare.
It's pretty rare. Yeah.
Correct?
Yeah, it's pretty rare.
Usually you go down one route or the other.
Yeah. Well, so I would say for most interventional pain doctors, probably 80-90% of the time they're anesthesia trained.
Okay.
So they're in the OR doing anesthesia. That's their main training. And they have usually 1 year of training in interventional pain.
Okay.
And then another 10-20% is for PNMR. So those are more rehab doctor. And then we as neurologists, it's pretty rare. That's less than 5%, maybe 2% of the interventional pain doctors are neurologists.
Wow.
Yeah, I think here in Oregon, I think I may be the only person.
Okay.
And there's another, I see another person, I think Eugene or somewhere, I'm not sure. Yeah, but it's really rare to have both trainings at the same time.
So people can consult with you and they can come in and you can be their neurologist if they don't need injections and all these other therapies we're talking about. You can help manage their case.
Yes, exactly. So it can be anything from, stroke, seizures, MS you talked about, can be Parkinson's disease, concerns about Parkinson's disease, memory issues, dementias,
and you can prescribe as well if needed.
Yeah. Okay. So if you need anything, let's say for Parkinson's, you want medications, we can prescribe it. If you have weird tingling, numbness, weird stuff that cannot figure it out, or your doctor cannot figure it out, then happy to see you and then do a diagnostic study, do a consult. I cannot guarantee that I won't be able to figure it out.
Sure.
10 other doctors cannot figure it out, but I'll do my best.
Yeah. No, that's great. Yeah. Thank you for explaining that. So if someone is hearing this, they want to see you, what's the easiest way that they could find you? Going Googling Nerve and Pain Institute, Tigard, how can they find you and make an appointment and research more?
Yeah. So just Google Nerve and Pain Institutes in Portland, and that'll be me.
Okay.
Or you can go to www.nerveandpain.com, nerveandpain.com. You'll be able to find me. And then you can also give me a call, and then can make appointments. Usually it's pretty quick to get into my clinic.
Okay.
So
it's a little bit different that you have your own, facility here, and you're not, deep buried in a hospital system where, Chiro like me.
call me urgent, and then I'll fit you in right away.
Okay.
I'll get you in quick.
I haven't asked this, but is there any reason you decided to, run your own business and your own practice versus working for a hospital system?
I never thought I would start my own business. Other than it, really honest, yeah. It was an interesting story. So I did MD PhD, so naturally I thought I was gonna be in like a hospital system, doing
Right.
like research and then doing clinical work at the same time.
Uh-huh.
And then so I graduated during COVID year, so 2020.
Okay.
So my wife found a job here in Portland, and it was in February, and in 2020 March, that's when I started to look for jobs.
Okay.
And you'll know March 2020 is when COVID hit.
Yeah.
And then everything shut down. And then that's when I started looking for jobs, and I called around and say, who's still looking for a doc?
Yeah.
To work.
Okay.
Nobody. I mean, literally nobody. So I looked for 2 months, and I said, well, it's it looks like I'm not gonna have a job. So why don't I create a job for myself?
Wow.
And that's how I started my clinic, and then it's being great.
That's awesome.
Yeah, I fell into it. It's doing great.
Some things happen for a reason, huh?
Yeah, exactly.
That's awesome. That's great. Well, thank you for sharing. Thanks for taking time out of your busy schedule to come here and, help us out and understand more what you do. Is there anything else? I just want to, leave a little bit of time here. Anything else that maybe we didn't cover or didn't fully discuss that you do that you wanted to mention here?
Yeah, well, the closing thought is that you don't have to suffer. You don't have to wait. You don't have to wait till you've done surgery or something for a long, long time before you come to see me. And then it's just like office visits, and then if it works very well, especially in some of these interventional pain procedures. So happy to be a resource for you, your clinic, and then for anybody who's listening in. Happy to be a resource.
Yeah, I appreciate that, and I know your name definitely does circulate around the chiropractic, physical therapy, natural medicine arena, and that you've done great work. Patients love you, and you've personally helped out many of our patients. So, I can attest to that. And so, thank you for coming on, and hopefully we added value to people listening. So, appreciate it.
Thank you.
All right,
for having me.
Absolutely.
Okay.